Good afternoon, dear ladies and gentlemen. In my presentation, I would like to present to you a development and research process related to biomechanical measures we use. And please bear in mind that majority of my research work has been done in healthy subjects and musculoskeletal injured patients rather than neuromuscular disease. But through a quick overview of the research done in neuromuscular progressive diseases, I found out that very consistently several of these assessment techniques have been used, and hopefully you will find these methods and techniques also useful for your clinical or research work. These are the topics I would like to present bottom up. So one is how we are trying to bring scientific knowledge on the field of diagnostics and measurement techniques into sports medicine, rehabilitation medicine, and sports field, deriving from the knowledge we get either through our research or through study of the literature. Then the main part will be presentation of a couple of examples of such measurement systems and approaches, and I will finish with one overview of the custom development of a more complex way of testing system. My background is in physiotherapy and sports science, and thanks to Dr. Dimitrijevic, where I kept on my research work in the Institute for Clinical Neurophysiology in Ljubljana, I'm also today here, and I thank for the invitation. Currently, I work between University of Primorska, Department of Health Study, and Ljubljana Technology Park, and the combination of the two is what brings me to the output which will be presented here as ways of biomechanical measurements. Here is schematically presented how we normally work. We try to identify the research or clinical needs for testing something that has been recognized as important for either clinical diagnostic purposes or sports diagnostic purposes, or in research. And then we try to bring it into life. But this is normally a long way, so on average we would need between 2 and 3 years and 4 to 5 prototypes before we get to the fully functional measurement system. For example, one of the last developed this way is postural 3D analysis of the trunk. You probably know that there are several systems on the market. We know that we have some of them of the ways for quantifying the posture during upright stance, might be even aggressive to the body. But video systems such as standard high-precision video cameras or laser-based machines, they are very weak in parameterization of the posture. So if you look at the market, you will find several systems, but the problem is how to quantify the posture. So the industry hasn't come much longer than nice pictures till today. So we tried to use the high-end technology of so-called structured white light and high-precision video cameras, from which we get in 1 second a 3D model of the back during upright stance. And from there, we are now bringing in the quantification of the curves and symmetries and posture of the scapula, for example, and now we are in the phase of validation of such a system from the perspective of standard contact measurements, such as pelvic tilt, for example, or indices of symmetries, and some other, and of course, repeatability. One other group of measurements I think is very simple to use, but the equipment we are using are force plates. So if we think, well, then the only force that is propelling our body through the space is ground reaction force. And if we can measure that one, then we can measure several movement behaviors. So for example, force plates are the ones with which we can measure 3D force in time. And this enables us to quantify the quality of basic postural, balance, and locomotion movement tasks or movements. If we take a look to the stability and balance, then you know that our body is quite unstable per se because of the high center of mass, small support surface, and the controlled variable is center of mass position about the support surface. But the controllable variable is the center of pressure. This is the start of the force vector on the floor or beneath our feet. And we can measure that in a millisecond of a time, how it moves during a chosen postural task. We can do that with different feet position. This is also the way how we can manipulate the size of the support surface, like in clinical environment using Romberg testing. The control of body stability integrates several sensory systems, such as vestibular system, vision, proprioceptive somatosensory system, and exteroceptive of the foot, for example. And all these may decay through aging or other processes of injury or disease. Standard classification into static and dynamic balance is questionable today, because we know that quiet stance, for example, is a very dynamic process and most often used for testing the quality of a subject's balance. So maybe reconsideration of the right terms would be useful. But standard dynamic balance can be tested either during a stance on a movable, unstable surface, or during voluntarily bringing center of mass in different directions about the support surface. Two main ways of testing. One is clinical testing and one is lab testing using the different posturometers, for example, most commonly the force plate. And the main difference is comes from reliability, repeatability of the tests, and sensitivity. For example, several clinical tests, such as forward reach test or star excursion balance test or Romberg test, they are all have this leveling effect where they are not sensitive to good or very bad quality of balance. The same problem we can have when using center of pressure parameters. That's why the standard would be 3 times half a minute balancing for a quiet stance task, or 2 times 1 minute. So we can average this in order to get a reliable measure for testing then the effects of training or progressive decay of the ability. We get a curve that that shows oscillations of position of center of pressure on the support surface, and different scientists or authors have proposed different ways of how to quantify it. Standard way, if you think about it, would be average velocity, average amplitude, average frequency, and among these, the amplitudes and velocities are the most reliable ones and most discriminative between good and bad performance. On the other hand, frequencies of oscillations are not that well reliable. Then we have several other structural ways of analyzing the curve, and the choice of the parameterization depends on our goal. For example, a rambling and trembling approach is one of the latest ones tested to be useful in the framework of so-called equilibrium point hypothesis as suggested by Zaciorsky and Latache. Then we have a group of dynamic balance tests, also reported quite often in neuromuscular disease patients, and among these, the star excursion balance test, when you are standing on one foot and manipulating with the other one, or so-called limits of stability, where the subject is asked to bring the center of mass as much forward, backward, and to the lateral direction as possible. And then different other ways of dynamically changing the position of the center of pressure in time. One of the ways is a so-called visual motor task that was brought from single joint tasks such as position tracking or force tracking. And some of the first studies have been done in Ljubljana by Professor Bajt, Kurillo, and other colleagues. And now it's more and more present in the quantification of dynamic balance based on visual motor tracking of the center of pressure. Together with the geometrical analysis of the posture and the body sway analysis of the dynamic posturograms, among neuromuscular disease subjects, very often is also used symmetry test for anti-gravitational activities. These symmetry or weight-bearing symmetry tests are performed in a way that we look at the sharing of weight-bearing between left and right side during upright stance, semi-squat, squat position, or rising from a chair. Here is the task rising from the chair, quantifying in the same way using the force plate, and very easily done. We need only half a minute for 3 repetitions, and it can give us complementary information together with, for example, scoliosis analysis during from the geometrical point of view. Because the rhythm between hip, pelvis, and lumbar spine is the one that changes quite much from upright stance to semi-squat or squat position, and this dynamic aspect of asymmetry in frontal plane might be an important additional information. Gait analysis, again, it can be done in a very complex way, like using 3D kinematics with several high precision and very expensive video cameras, but very high correlations between ground reaction force in time and kinematical parameters have been shown. So for simplification in a clinical environment, already stance phase of the step can be useful. And study done by Gali et al. In 2012 is a nice one that shows how the ground reaction force changes and kinematics of the gait changes in myotonic dystrophy. A couple of main messages in this study were that the pelvic tilt increases, mid-stance knee hyperextension results in higher peak of the braking force. Braking subphase of the stance is the first part where the posterior force, shear force in sagittal plane is the highest, which decreases the velocity of the body in forward direction. And the last group of the tests, if we shift now from force plate measurements or ground reaction force measurements to the classical dynamometry, everybody probably knows the hand grip dynamometer that is most often used. But interesting questions would relate to differences between distal and proximal muscles, decrease in the ability of developing the maximal force or rate of force development. And these are the other parts that we are working on. So development of different types of isometric dynamometers, where we can then quantify again not only maximal force or torque developed by the muscle group, but also rate of torque development, rate of force development. This parameter, for example, was shown to be much highly correlated than maximal force alone in the context of fall prevention in elderly, or the correlation with stability and balance parameters was pretty high for the rate of torque development in the first 50 to 150 milliseconds time window. Then the other aspect would be, as shown in the top right graph, the endurance in local muscle strength. So how long can a subject endure the force, the goal force, which is normally starts between 85 and 90% of maximal contraction, and we measure the time and dynamics of decay in this maximal force until the subject is not able to sustain at least 60% of the maximal force. The below figure represents the standard twitch response, which can be measured in combination with such dynamometers and electrical stimulation. As you know, single electrical stimulus or double or triplets are normally used and then quantified through contraction time, half relaxation time, and maximal force or torque, depending on what we are measuring. Here is the last slide. This is the example how we normally, either for our own research purposes or in combination with our partners, also do majority of custom development. So in this case, it was a bigger project on the trunk. I don't know what's that. On trunk stability functions in the context of low back pain prevention and rehabilitation. And this device encompasses actually front dynamometry for trunk extension, flexion, and lateral flexion that we quantify in a way as I presented before. Then trunk repositioning error testing using special sensors for orientation of the trunk segments called inertial measurement units. Then responses of trunk muscles measured by EMG as responses to sudden perturbations that we apply over the trunk or hands, and then we look at reflex delays of trunk of lumbopelvic stabilizing muscles. So this is one such example of a complex approach to one clinical problem such as low back pain, which is among the most common musculoskeletal problems in working population, for example. And on the other hand, the same methodology might be very interesting for progressive neuromuscular disease, where we know that proximal stability and proximal strength is the base for general balance and stability is the base for locomotion. If we don't have stability and balance, then we can't also perform dynamic movements of manipulation or locomotion. All this wouldn't be possible if there wouldn't be a large enough team of young, vibrant colleagues from different disciplines, software engineers, mechanical engineers, electro engineers, and physiotherapists with whom I am working. Thank you.